We should get started. Thank you all for joining us today. We're here to talk about a challenging topic, tobacco regulatory policy. It's of interest to me. Many of you know I'm an FDA product regulation wonk and a payment policy guy. So just some numbers for us. Smoking-related illness costs $225 billion in direct medical care and $156 billion in lost productivity per the recent estimates from the Centers for Disease Control. And I like to say also, it's not just about numbers, it's also about people, right? You know, my grandfather died of COPD, so those numbers are individuals, and it's not fun, and it's not easy. We have a good panel, I think, today, which we'll introduce later. But first, I have one of my favorite members of Congress here, the only cardiothoracic surgeon in Congress, Larry Bouchon. He also trained in Chicago, as did I do. Went to MCW for his surgical training, practiced as a cardiothoracic surgeon for quite a while before he joined Congress, and he's the vice chair of the ENC Health Subcommittee, and he's a leader on FDA regulatory policy. So thank you for joining us.
It's great to be with you. It's great to be with you.
So, you know, as a physician and as a member who's involved intimately in health policy, what do you think that we should be doing with tobacco-related illness?
Well, obviously, and I have some opening remarks here if you want me to go through these, but obviously as a cardiothoracic surgeon, a lot of the patients I took care of over the years had disease processes, coronary artery disease. I also did vascular surgery, so carotid artery stenosis, peripheral vascular disease, that was partially related to tobacco-related products. And so for many, many years, of course, I've been an advocate for cessation. You know, both my parents, though, smoked. When I was a kid, my mom started smoking in the 8th grade. And even though I became a doctor, I couldn't convince them to quit until many years later, and they finally did in their late 50s, early 60s. But I think the basic fundamentals of this space is that government bans and those type of things don't really work. I mean, we've tried that over the years. Education does work. I think we had some success probably 20, maybe 30 years ago, starting in the schools. It has to start young. You have to educate young people about something that can happen to them when they're adults, many, many years later, and that the downside of using these products from a medical perspective is there. And I think we've had some success in the education space doing that over the years. I think in the United States at least, the number of people who smoke cigarettes or use tobacco products, let me just say this, my dad quit smoking, and he continued to chew tobacco products, is lower than it has been historically, but worldwide, as you probably know, it's particularly in Asia, it's still a pretty substantial problem from a medical perspective. So I think the one thing you need to do is make sure whatever your regulatory process is that you recognize that banning, specifically completely banning products, doesn't necessarily work. You will create a black market for these products. That's been shown in other countries, and it will happen true also in the United States. But you need to educate people and then make them, so that they can make informed decisions about how they choose to utilize these products.
So I think about my grandfather, as that he passed away from COPD. He did eventually quit smoking in his 70s. And he was probably a 2-pack plus a day smoker, and taxes and other public policy interventions obviously have reduced the burden of tobacco-related disease significantly.
Yes.
30 million Americans still use combustible cigarettes.
Yeah.
What do you think our public policy goal should be for them? What's a realistic public policy goal?
Yeah, that's a tough question. I mean, over the years, both at the state level and particularly at the state level, tried to use monetary policy to influence people's behavior, personal behavior, taxes, basically. With a moderate degree of success, I think I'm not in big favor of sin taxes, but I mean, I'm just telling you what has happened, including in the state of Indiana, and that has had some effect. I mean, when you get to the point where, it's affecting you monetarily, as I mentioned, both my parents continued to smoke, and one of the things that why they quit was because it did get quite expensive, as they lived in Illinois. But also, interestingly, I'll tell you a story about my mother real quickly. She was a nurse, still is. She's just retired, and the reason she ultimately quit smoking is because the hospital she worked at got rid of their smoking areas in the hospital, and the only place you could smoke was outside, and so she lived in central Illinois in the wintertime. It was so cold. She's like, I got tired of going outside in the winter just to smoke a cigarette, so I quit. Like, well, whatever it takes, mother, to get you to quit smoking. It's not the medical effects. So, I think monetary policy can have some effect. Again, public education has some effect. I mean, I'd be interested to see what your thoughts or the panel's thoughts are on that, because, I've found, I mean, is it surprising to anyone that with all the knowledge we have about these things and other things that we do to ourselves, that result in accelerated physical disease processes, that we still have a substantial level of usage, or what I'll call non-compliance? I mean, you're a physician, the compliance level, for example, of people taking their antihypertensives or their managing their diabetes, even though with all the best education that we've had, and the same thing's true in the use of tobacco, we've made a dent in it. The other thing we can do, I think, is, from a public policy perspective, is make sure that we have that we. I think people use these products somewhat. It's not just physical; it's emotional, and make sure that in places that we can be helpful, that we have programs in place to help support people with stress-related problems, depression-related problems, other things that typically will push people, I think, more to using, whether it's tobacco products or whether it's narcotics, other things, or alcohol, particularly. Again, but you can't mandate things because it's personal behavior.
So, I guess thinking about those 30 million combustible users, obviously the goal is cessation, right? Nicotine replacement therapy, patch, gum, lozenges. I've had patients who've been successful with them. It still can take 7, 10, 12 times to quit. Then there are other patients who aren't necessarily interested in quitting.
That's true.
What do you think we should do for them?
I think there's not much we can do. Again, I think if you try to do, for example, just hypothetically say, you ban cigarettes, all right, immediately creates a black market. And then what that does is then you get outside of your regulatory space. So you have a black market for products for people that just don't have any intention of quitting. That won't work. So I'll be honest with you, I don't know the answer to that question. I think it's just a certain percentage of people are just going to use these products. Again, for a multitude of reasons. I mean, I think also recognize that even though there is a physical addiction to nicotine, of course, and it so-called upregulates your nicotine receptors in your brain, and it makes it hard to quit. There's a psychological aspect to this also, and that's why I think, in some respects, products that have been shown to address that, for example, having something in your hand, have been slightly more successful. I don't have the data right in front of me, than like gum, for example, right? So I'm not sure what we have to offer other than education and make sure that the products that are available are safe, and are not coming from a black market that may or may not be safe.
Right.
And that's about all we can do.
I mean, and one of the things that's interesting, one of the things I've long talked about that's interesting about the FDA is the different FDA centers, right? And the Center for Tobacco Products is the only regulatory center that is overseeing a product that we know is overtly harmful and can kill people.
Yep.
Yet, the center seems to lack the urgency, what we would describe as the urgency of now. So, we think about tobacco product review, right? They had millions of e-cigarettes or electronic nicotine delivery system products. And it's sort of slow like it was in the 1980s. And I guess that you failed as a regulatory center when the nice pediatricians are suing you and asking you to make a regulatory decision. So if the pediatricians are angry, we probably know that as a market regulator, they've made a mistake. They also don't collect user fees from e-cigarette manufacturers, right? So they have to use other funds that they get to regulate an explosive marketplace that has millions of product applications. In some ways, you could say that's almost unfair to the agency. What do you think Congress should do about this, if anything?
Well, I always think Congress should act and not allow executive branch agencies to regulate. I'll just speak openly from a legislative branch person. I think where we can, right? Obviously, that's not always our role. Let me just say, I think, for example, in this particular space, I mean, you mentioned it from the beginning. The goal would be cessation, people not to use these products, right? That's not going to happen if you're. I understand the FDA. The FDA says, well, we don't want to regulate a product like, say, for example, an e-cigarette when we know nicotine is bad for your health. And yes, that's true. On the other hand, you have to recognize there's going to be a group of people out there that are going to be using potentially, unregulated and certain potentially black market products. And so it depends on what you see your role as. And if you see your role as well, if they don't quit using them, then we're not going to help them because, we're just not going to do anything. Well, I think that's not the proper approach. I think they need to look more closely about how, obviously minimizing the impact of the usage of nicotine products, but also recognize the fact that if they're going to be utilized, then their role probably is public safety also, right? And make sure that the products are safe, the products are what they say they are, right? And they're not. And we found that to be true, that some of these products aren't what they say they are. They have other things in them that are very damaging. So I think the approach would be they need to really reconsider not doing anything.
It's actually interesting that you mentioned that we need to. I think what you're talking about is the principle of meeting people where they are.
Yeah.
Right. Some people want to quit. Some people don't. Can we meet them somewhere in the middle, that population on the path towards cessation, harm reduction as the path towards cessation? I practice medicine in East Baltimore, in addition to being an internist, I'm a public health physician. I prescribe methadone, I prescribe Suboxone. Having patients not use IV fentanyl is a huge win for me as a physician and a huge win for society.
Absolutely.
Do we think that some of these potentially lower risk tobacco products could fill that role? I would say potentially yes, if regulated appropriately. There are a lot of groups that are concerned about youth access. I'm fully concerned. Any child who is using a tobacco product is a public policy failure on our end. I guess the question is, are there things that the FDA could do to prevent youth usage?
Well, again, I think yes. I mean, I think there are, whether that's regulation or whether that is using their platform for educational purposes. Let me just give you a little bit of an idea of the scope of the potential problem in child use. You would think that it's not as common, and I didn't. My daughter went to lived in D.C. here from 7th grade through high school, went to one of the D.C. private schools, prominent private school. I'm not going to mention the name. And she told me that the Juul usage was rampant in her school. And I know the parents, I know the kids, I know the people who are there. If you were an outsider looking in, you would say, no way at that school are all these kids carrying around Juuls. Well, they are. And so the problem is substantial. And so I think, yeah, I mean, certain things the FDA can do to make sure that that there's an educational process for not only the kids but the parents. I mean, yes. Are there certain products that occasionally that need to be banned? Yes. If there are products that are, for example, I was kind of on the, and you may agree or disagree with this, but I was back in the day on the forefront of trying to get the flavored products more regulated and less not available, because those are the ones that the kids tend to use, right? All the flavored Juuls and stuff were the most popular. So at least, make it so that the availability of these products wasn't as prevalent. And I think that has happened to a certain extent. I don't think there's a silver bullet here, though.
Yeah,
I really don't.
I don't think there's a silver bullet either. And, I think some of it is, you said, it's education, but also sales and marketing.
Yep.
And then where are the products sold? How are they distributed?
And we had some success there in these flavored Juul products and stuff like that, right? But I think the thing is to recognize the extent of the problem with these. And I didn't even realize myself till my daughter, who was at the time in 9th grade or 10th grade, and she said none of the parents know, but they're carrying. Remember the little things? They look like thumb drives, right? They carried them around.
And I think what's interesting about that is that the product market regulator, I would say, has actually failed on both fronts. Yeah. And so the Center for Tobacco Products, in the long term, has not succeeded on either creating a harm reduction marketplace that is available to current combustible users who don't want to quit, which is millions of people.
Yeah.
And at the same time has not counterbalanced that by the need to prevent youth access and youth use. And the agency actually can do both, but requires it to be creative. It requires it to engage with all stakeholders, including probably some people the agency might not want to engage with. And then it also requires what I would call the urgency of now. Like all the other, and the thing that amazes me as a public policy guy, and you probably feel similarly, is that all the other FDA product centers understand their space, right? The Biologics Center understands that gene therapy, for example, could change someone's life, right? It could change that patient's life. The Oncology Products Group at the Center for Drug Evaluation and Research also understands that the alternative to not having a therapy is death, right? Like if we're a last line therapy. But for some reason, when we go into the tobacco product regulation space, the center, as I said, it got sued by the pediatricians to make product market decisions. We don't have product standards, right? EVALI, the e-cigarette vaping-induced lung injury, which was found to be from a vitamin E solvent, which is a form that was not authorized to be put in. That's product adulteration. That is a complete failure of regulation, and that's from a lack of product standards, which to me is, as I said, as a former CEDAR medical officer and product reviewer, it's amazing to me that we're operating in a space without product standards, without detailed guidances, without industry standards, that then obviously support product regulation. And the FDA has not engaged over the last decade to produce these, I think. And it's a huge public policy failure and has resulted in combustible users, millions of combustible users that don't necessarily have a great set of alternative options when they don't want to quit. And then, of course, youth usage. Yeah. So we actually got the worst of both worlds instead of the best of both worlds.
Yeah, I think that's right. I mean, I agree with basically everything you just said. I think from my standpoint, you asked what Congress can do, legislatively. I mean, you tried to address some of these things, but I'll be honest with you, particularly on my side of the aisle, on the Republican side, people are very reluctant to give the FDA any new authority or assign any new authority legislatively to the FDA. I've found that to be the case in laboratory developed testing and other areas. So when I was working on the flavored jewels and all that type of thing, I had these discussions with colleagues on my side of the aisle, and they were very reluctant to legislatively take action as it relates to the FDA, which was probably a mistake, because of the things you pointed out. However, where there are legislative blind spots. I just want to make clear, I'm not against regulation. I'm against unnecessary, costly, ineffective regulation.
Absolutely, which is unfortunately
So that's the challenge, right?
which is unfortunately what we have right now. We have cost-effective and ineffective regulation where we spent billions of dollars,
Correct.
and we don't even have product standards a decade into a new product market being regulated by the agency.
That's correct.
And I guess the thing, the agency says that they don't have enough money and they don't have enough staff. If we take that at face value, then maybe we should give them user fees to support hiring the technical staff, creating that regulatory infrastructure, which in the long term is going to promote the public health.
It's not a bad idea. That's been a massive success in the medical device space, and as an example, and in the pharma space, been a very big success. Let me just say this from a legislative branch's perspective. Does anyone ever heard of a federal agency that doesn't say they need more money? And I'm saying that because, well, nobody laughed, but it was a joke. But I tried, I'm not a comedian. But the reality, my point to that is sometimes that's true. But many times it's the lack of will or the inability of the agency to repurpose, some of what they already have. Sometimes it is money, no doubt, and it definitely is a staffing issue in a lot of ways. You saw that with what happened in the food product area when we had the baby formula situation, right? They actually are way understaffed and don't have enough money to do the proper oversight they need to do. That's real. So, yeah, I think that's not a bad idea. User fee concept, is something that's been proven to be successful.
Do you think, given the significant focus that there's been on cannabis policy and cannabis legalization, cannabis would most likely be regulated under a harm reduction standard, very similar to how tobacco products are currently regulated. Do you think that as a necessary prelude before we have any more discussions about cannabis, that we should fix tobacco product regulation first?
Well, probably. It's, the reality is obviously people have been using tobacco products for centuries, right? And we've in the U.S. we've had a modest degree of success of decreasing that from a medical perspective. But yeah, probably. But I think they're two separate issues, honestly, from a medical perspective. Again, I have my own view on legalization of THC products. They're a big moneymaker for the states, for example. I think a lot of the legalization movement is driven by money. From a medical standpoint, again, we may agree or disagree on this, but it's been shown in the developing brain that chronic THC use results in long-term cognitive deficits or problems. And so we are talking about child use of jewels and other things, right? We'd have to be, if we're gonna legalize THC products nationally, and that movement continues, we're gonna have to be very aggressive, in my view, in the so-called developing brain aspect of our fellow citizens, and that actually goes up until age 26 or 27. People don't realize
for some of us
that's
men,
the
it
case.
might continue into our 30s.
Yeah, my wife would argue maybe that it's still ongoing, right? But in all seriousness, I think it'd be nice to get the tobacco piece right first, right, and then try to address that. But I do think that we're going to have to do something. We're going to have to address something at a national level as it relates to THC products. Let me just say one thing that's maybe a little different between the two. Also, because THC is a Schedule One drug, right? The amount of research that has been done on the medical problems, potential medical problems related to chronic THC product use is just not there. I mean, as much as you would think. So that's a little different than you see in the tobacco problem. I mean, we know the tobacco situation for decades now. So we have to maybe address that first. I mean, some people are saying, well, maybe we should put THC as a Schedule 1A or move it to Schedule 2 or something so that we can do research and get more information before that will inform us in what regulatory framework maybe that we need to have at the national level for those products.
Seems reasonable to me. I would say that for products that we know are addictive and potentially harmful, not only do we need appropriate research, but we need a functional regulator.
We do.
And right now, we have and I'm a huge fan of the FDA, so it sort of pains me to say this, but like in the tobacco product space, we have a completely dysfunctional regulatory regimen. I've enjoyed our conversation. I also want to open it up to questions because I've monopolized your time.
Can I just say something? Finish.
Yeah.
First of all, thank you for inviting me. And secondly, I just want to follow up a little bit on the THC product space and why research is necessary. Because there's a disagreement on the harmfulness of these products amongst our fellow citizens. Some states have legalized it, not recognizing what the National Center for Drug Control policy that's run out of the White House, I think that's has had information on this for a long time. So there's a disagreement there, and that's why I think partially we need to look hard at a way that we can study it more. That's part. I just wanted to follow that up. That's a final thing on the THC products.
I agree wholeheartedly, and I think the other thing is we don't want to replicate the mistakes that we made with one product market for decades in another product
Agreed.
market. So I have some questions here. Any questions from the audience?
If usually when I do these type of things, if I don't get any questions, I start calling on people.
Oh, yeah.
Can I do that?
Like medical
I'm
school.
kidding. I'm kidding.
Hold on, voice. But hi, I'm Mazen Saleh. I'm with the R Street Institute and lead a policy department looking at integrated harm reduction across a variety of behaviors that carry risk, whether that is opioid and other illicit drug use, cannabis, tobacco, things of that nature. We hear quite a bit around the dangers of e-cigarettes and other kind of nicotine-containing products, but nicotine on its own is a fairly benign stimulant. It's really the delivery modality that delivers harm. So whether that's the combustion of burning tobacco and cigarettes or cigars or things of that nature, otherwise we wouldn't have things like Nicorette on the market, right? And so I'm interested in asking about the education component. So we know the majority of physicians in the United States incorrectly believe that nicotine is the main agent that causes cancer and other burdens of disease. And I, in full transparency, worked for the Association of American Medical Colleges for a decade and had very intimate experience with curricular change at the national level and through all of the medical schools and teaching hospitals and know the slow pace of that. What do you think the FDA or the government can do to kind of help to fill in the gaps in the education bit, particularly around nicotine and cancer and some of these novel products that don't carry that same lethal risk?
Yeah. I mean, I think. I think people in medicine know that when you burn tobacco and you inhale the smoke, there's over 200 different types of compounds in there, including many carcinogens, and that nicotine although is addictive, is not one of the primary damaging things that you inhale or that you chronically have under your lip as it relates to tobacco products. I think I think most physicians understand that. I think for the most part. And so it's more the public that needs to understand that. If there's going to be more people using like a vaping product or something versus traditional cigarettes, there has to be an understanding that it does mitigate risk. It doesn't take you to no risk of anything. You should not use these products from a medical perspective. So that's the first step. I mean, I think the public and you can comment on this as a doc too, but getting a message to the public as a whole on certain, I mean, I'm a politician too. I can just tell you, getting a message to 700,000 people in my congressional district is really hard. I mean, you can do all of these things and then and messaging, and then you can go and do a town hall, and I would say 90% of the people that, and they're good people, educated people, just, the American people overall are overall educated people compared to people around the world. And they have no idea that you've been talking about a certain subject for months or years. Medicine's very similar to that. So it's going to be a long-term project. I mean, I think, you just saw these alternatives to cigarettes. How long they've been in the marketplace? Maybe 25 years or so?
15, 20 years.
15, 20 years. That's a short time frame when it tries to convince people, in my view, of the medical benefits or negative aspects of this. And it could be we'll see the data more data in the future that will show, like people, for example, if you're 25 years old and you're not smoking a cigarette but you're vaping, 25 or 30 years later, you may have an instance of lung cancer that is 1/100th of what it would have been for a 25-year-old who was smoking a cigarette. But we don't have that data right now.
Right.
So to try to convince people, oh, doc, how's this going to help me? Well, to try to convince them it's going to help them 30 years from now from my perspective, is pretty hard. So I don't think there's a silver bullet here. I think it has to be a long-term concerted effort. I do think when you're talking about FDA and just avoiding the regulatory, not addressing this, is a mistake.
Yeah.
And it's going to take, but it may take years for us to really mitigate this issue, to get there.
As I always say, I'm with you. I'm a big fan of taking action as opposed to not taking action. The FDA uses it being passive-aggressive as a regulatory strategy for the product market regulation, and tobacco is not a good regulatory strategy.
No.
It needs to be proactive. To the communications question, I agree with you in that it's going to be a massive educational undertaking. It probably needs to come from a variety of sources. FDA needs to be part of that. It can't do it all by itself, right? Because some people will trust the FDA, others won't trust the FDA, especially after a lot of the strife we've had over the past couple of years. But having a public education campaign for physicians, other nurses and other clinicians, also the general public, about the risk continuum of tobacco products seems like a common sense, nonpartisan thing that we all should agree on and the agency should be doing, although it is still not doing a decade into its existence as a product center. Well,
Yeah.
I've enjoyed having you here. I appreciate you being so
Yeah.
generous with your time.
Sure.
I know you have a lot of places to go, and we've taken more than allotted, but let's give
This is fun, though.
let's give a round of applause for Dr. Bouchon.
Thank you. Ready?
We'll transition. of our event today. I think, this is a particularly, I'll introduce my colleagues, but I think this is particularly salient that we're talking about tobacco regulatory policy, given the current administration's cancer moonshot, and that this is an important component of it. I have three of my colleagues who represent sort of three different perspectives and skill sets and backgrounds. First is my friend and colleague from Hopkins, Brian Yagi, who's an assistant professor of medicine. I would be remiss if I didn't mention that in addition to being a hospitalist, he's also a lawyer and an expert in the intricacies of FDA regulatory policy. I joke if I have a question, I ask him if I can't find it, because it's probably, I read the guidances and he reads the Federal Register. So between the two of us, we got the FDA covered. My friend and colleague, Dr. Boris Lushniak, who's the Dean of the University of Maryland School of Public Health. He's also the former acting Surgeon General, and he served 27 years in the US Public Health Service as a commissioned officer and trained in dermatology, family medicine, and occupational medicine. And then lastly, Georges Benjamin, a longstanding public health leader who is the executive director of the American Public Health Association and worked as a practicing physician, a city health commissioner, and also a state health secretary prior to his years in policy. So he has experienced it as a clinician and then also implemented policy as a leader at multiple levels, which few people have. So we're going to continue our discussion that we started with Dr. Bouchon. I wanted to start with you, Boris. You oversaw the 50th anniversary of the Surgeon General's report on smoking. You're both an idealist and a realist. What steps do you think we should take to lower the overall burdens of tobacco product use in the U.S. while also protecting youth?
Well, first of all, we have to acknowledge the fact that we've made incredible progress in this arena. I mean, let's pat ourselves on the back, right? Public health has done incredible things, right? And as you mentioned, it's actually 10 years ago in January that we issued the 50th anniversary report, which makes it, according to my math, 60 years we'll be commemorating since the first Surgeon General's report on smoking and health, 1964. 1964, a guy named Luther Terry, a Surgeon General of the United States, he in fact is a smoker, right, as Surgeon General, right? We have to remind ourselves that that's not that long ago that those two disparate ideas actually took place, right? And what we've done in those 60 years now is we've moved from a society where we used to have, in 1964, 42% of adults were users of burnt tobacco products, right? We're cigarette smokers, 42%. Now we're down to what, 11.5%, 60 years. So great job, us. And yet what we realize, and you've mentioned, is the fact that we're still not there. Right? If you look at CDC statistics, 480,000 deaths per year, direct or indirectly attributable to cigarette smoking. We still have a society that has determined that, right, that cigarette smoking is still part of us, burnt tobacco products. We see the issue of the discrepancies, the difference in our society, right? Certain people smoke, certain don't. And in the midst of all that, we have to acknowledge that we've done some good. 1999, CDC came out in its Morbidity and Mortality Weekly Report with the 10 major public health achievements in the 20th century. And one of them, and this is a key noun, one of them was recognition of tobacco as a health hazard. And I'll submit to you that I think we are capable in this century to actually substitute recognition by the word elimination of tobacco as a health hazard. But that means we have work to do. And I think part of your question is, what do we need to do to get better? From 11.5%, some percentage of that are what people deem the happy smokers, people who are fully informed saying, I still want to do it. Others are smokers who may go into it not realizing both the elements of addiction from nicotine, but also the elements of that it's bad for my body. And I think we have to go back to the basics. We have to go back into health communication. We have to understand health literacy in the midst of all this. We have to take into account what are the youth of America doing, both in terms of other products, i.e. the vaping surge, but also the whole idea that when we look at the demographics right now, who are the smokers? Right? The smokers are, percentage-wise, the middle of the road. The 25 to 65-year-olds are the smokers. Less than 25, single digits. Over 65, single digits. Right? So we kind of know what's happening out there. And the question is, how do we influence that facet of our society to not take up combustible products as a form of, and then fill in the blank, a form of addiction? Well, no, nobody looks at it as a form of addiction, a form of entertainment, a form of peer pressure, a form of satisfying urges, a form of relaxation, a form of weight control, right? We have multiple reasons why people do this. And the question is, we are good enough right now to delve into motivation and to be able to work at that level.
Thank you. You've been a public health policy leader. You've done it. Like, not many people have actually implemented policy. Like, a lot of us write about policy, but actually making it a reality is a challenge. You've done it at the state level, you've done it at the local level. The public health community is understandably very frustrated with the FDA. A lot of this comes from tobacco regulatory policy decisions and sort of a sense that the agency is focused on talk as opposed to action. And Dr. Bouchon and I talked about how if the pediatricians have sued you, we're probably not operating from a place of success. So what do you think we can do to push the FDA towards action, and what do you see as the key levers and key barriers?
Sure. I think one of the things that in public health we've got to do is move from kind of the mindset of implementing policy at, in many ways, at a snail's pace, to a more urgent approach to this. As you know, I spent a fair amount of my time, I trained in internal medicine, so I always had the experience of being contemplative and dealing with disease based on a diagnosis that I know, but I spent most of my time practicing emergency medicine, which means acting often before you have all the information that you need, but enough to basically take care of the patient. And I just think that there's a regulatory mindset that we need to move to. And it's not just the FDA, it's really all of our health regulatory agencies to dealing with the urgency of an urgent problem. I think what Boris pointed out, that 480,000 people is a big number, but it's even a bigger number when you think about the fact that these are preventable deaths. And so I think we need to behave as though these are preventable deaths. And that means having the regulatory speed of not doing this in this due course. Now, as you know, the regulatory process moves at a snail's pace. There are many people involved in that process. So it's not just the agency that has to speed up its activity, but it's every aspect of that. And we need to figure out ways that we can move it through a process that's very transparent to the public, because not engaging the public causes lots of trouble. Because the public has to understand why you want to do something. The public has to have its input, and they have to be engaged. But, we have a regulation right now around menthol that's been sitting there. And at least the scuttlebutt is it may slip into 2024 when the evidence is very clear that we need to regulate menthol as a flavor in tobacco. And yet the evidence has been there for many years, and now it's kind of sitting in the system. And we need to move those kinds of regulations through very quickly. I think the other thing we have to do is build an environment where we can address some of the legal processes early on, because as you know, every time these regulatory agencies do something, they're protecting themselves against a lawsuit. So they're not just doing what's appropriate from the health perspective, but they've got to do it in a way that minimizes the opportunity for an adverse decision in the courts. And that also takes time. So I think we've got to figure out how we do that both quickly, with due process, but also protect the right of those agencies to come out with a favorable decision that protects the human's health.
Yeah, it's interesting. You mentioned lawsuits. So I remember my colleagues at CMS, and I worked for 4 administrative agencies. My colleagues at CMS, the operating assumption is that they would be sued on almost every reg.
Yep.
But they still actually manage, and some of my colleagues may disagree with me on this, but CMS still manages to get stuff done. And they're regulating over $1 trillion in medical expenditures. So I guess I would posit that, yes, I understand the risk of lawsuits, but other administrative agencies have been successful. We need to find ways to help the Center for Tobacco Products be more efficient and more effective and make decisions and move the public health policy, frankly, forwards.
And they would argue some of that's infrastructure.
Yeah, right.
And I would argue that they don't have sufficient infrastructure to do some of the things they need to do.
Right, and when they were doing those reviewing, I almost said multi-million, it was 6 million, but 6 million ENDS products applications, they actually had an emergency call out for reviewers from other centers. So reviewers from a medical office from other centers could go work at the Center for Tobacco Products for a couple weeks. We can debate as to what the quality of that review would be. Some might say it'd be really high because the CEDA reviewers, as a former CEDA reviewer, are very good. Some people might say they don't understand tobacco product regulation. It didn't turn out very well. But regardless, the infrastructure and staffing and funding for that is something that has been a continual concern. Brian, you're an expert in sort of the FDA process and product regulation. Can you explain how user fees work for other product markets and how the tobacco product market is different?
Definitely. So user fees are the cornerstone of how the FDA kind of funds its regulation of pharmaceutical products and medical devices. There are, biosimilar user fees and other product areas, but those 2 key centers of the FDA get about 60 to 70% of their funding from user fees. And the way they're structured is meant to be roughly commensurate with the amount of work that the FDA has to do in its regulatory process. So the fees for a brand new application, for a brand new drug in a brand new class that's never been approved before will have a higher user fee than, say, like a fee for just reviewing the manufacturing facilities after a drug has been reviewed. So they have this long, kind of sophisticated 5-year renewal process where Congress gets to look over how things have been going over the last 5 years. Industry comes and sits down and talks to them about what their legislative priorities are. There's patient advocacy groups that come to the table for these 5-year reauthorization discussions. So it's a very robust public health discussion about how to get the agency to regulate these products in a way that helps patients. And right now, the way that user fees or the way that CTP is funded is from the Tobacco Control Act, and it lists 6 distinct, I'll call them traditional tobacco products from which the FDA can collect user fees. It's stuff like roll your own tobacco, cigars, cigarettes, the classic stuff. But notably, what's not in those 6 enumerated classes are ENDS products or vapor products. And if you look at the FDA's website for the percentage of PMTA applications that they've received, they have this pie chart, it's the first chart, and everything, 99.5% of them are from ENDS products. And that little sliver where they have to blow out and list all of the individual products is your 6 classic tobacco products. So effectively what this means is that CTP can collect user fees from old school tobacco products, but they can't, or they have to kind of redirect those funds for all of their ENDS product regulation. So it's like robbing Peter to pay Paul. And that in turn has led to the timeliness problems that we've talked about. But I think the bigger problem is with transparency. And I think we're going to get into that, so I'll stop there.
Yeah, we talked about timeliness. It's sort of funny. because it's like we're going back to the future and we're at drug review in the 80s, right, where you had the AIDS epidemic and you had a bunch of products that were available in other countries but not available in the US. And so patients literally had a death sentence because product review took 4 to 6 years, sometimes shorter, but still a long time. Now you can get your product reviewed even faster, actually, if you have a priority review voucher or your product gets priority review. Brian, do you think that user fees could solve the timeliness problem?
Yeah, definitely. All of those things that you just mentioned, like the priority voucher, kind of prioritizing rare diseases, all of those came from user fee acts and those 5-year reauthorization bills. It's what we call regulatory innovation. This is new technology that people are developing, like Juul wasn't in existence when the Tobacco Control Act was written. So why not have something that sunsets every 5 years so that new technology can be considered by Congress and the FDA and patient advocacy groups and public health organizations. So all of these regulatory innovations can happen through a user fee act structure.
And we talked about stakeholder input, and this is a question I want each of you to answer. Do you think that stakeholders have an opportunity to participate in the formation of tobacco regulatory policy?
Well, they certainly have an opportunity to participate, but I think we can increase it for sure. But again, like everything else, it takes resources. You know, if you want to put something out, yes, it can go out in the Federal Register, but it does require people to have the time and effort to engage, and then the agency has to have the capacity to accept all of that comment, go through it, intelligently analyze it, and then apply it to the policies and procedures you want to do.
Let me take sort of the concept of the stakeholder to a whole other sort of level above things. And I think this is something that I've been certainly, involved with as a public health practitioner most of my career, which is at some point we have to acknowledge, right? We have to acknowledge, is health a priority in this nation? Health of an individual, health of a community, health of our nation. And I think when we talk about stakeholders, I think what we've not necessarily heard, we've done a lot of lip service about saying, oh yeah, the health of the population, that's important. But then we back away, right? We worry about terms like, oh my God, they care too much about us. And there's a derogatory term towards public health of being part of the nanny state, right? Leave us alone to make our own decisions. But I don't think a nanny is a bad thing. I don't think a parent is a bad thing. I don't think a physician is a bad thing or a public health practitioner if their goal is ultimately to make the lives of their patients, of their family members, of their citizens better. Right? No one wants an early death. No one wants an early painful death. No one wants to do the bad thing for one's body. And I think when you talk about stakeholders and their input, whether it's sort of the ends products and user fees and all that, I think it allows us to actually go back to the biggest stakeholder of all, which is what is our community? What is the U.S. federal government? What is state government? What's local government? What are, sort of the interest groups out there saying about the health of the community? And is that a priority? Because right now it's not being treated as a priority. What it's thought of as it's kind of optional. Do whatever you want. I put the Surgeon General's warning label on the damn pack of cigarettes, and that's enough. I really think we have, as George just mentioned, this is the number one, not number 2, number 3, number 4, number 5. It's the number one preventable cause of death in this country. Number one. Why are we sort of just relegating this to just a side discussion? Why have we forgotten the 60 years of progress? Right? I'm a preventive medicine type person. And the idea of preventive medicine is you get ahead of the curve before the problem develops. And I think the stakeholder needs to be all of us. We have to sort of say this is costing our nation a ton. It's costing our citizens, our people, early life lost. Its economic, its social, its emotional repercussions are immense. Let's bring it back and let's make this important again. I think that's a stakeholder in all this.
I mean, before you comment, Brian, I just have to say I absolutely agree. The fact that, we're having a panel talking about tobacco regulatory policy, and that this is a more recent thing in the health policy community and hasn't really been a focus about what to do about the FDA and how to make the FDA more efficient and effective at promoting the public health in this space is shocking to me, right? The Tobacco Control has done a lot of work on taxes, marketing, advertising, but tobacco has been an FDA-regulated product for a decade now. We should have made more progress, and we should be more interested in making product regulation efficient and effective to promote the public health. After all, the regulatory standard is appropriate for the protection of the public health. And it seems, and part of public health, as we've seen, is having that sense of urgency and having that sense of priorities. And frankly, this is a part of the FDA that, as I said, it's weird to me, does not have that, and the other centers do. And you talked about outreach. The other centers regularly are out engaging with all kinds of stakeholders in the community, people that agree with, people that disagree with, people who are their friends, who are not their friends. The Center for Tobacco Products has not done that. And that to me is a mystery for the one product market that we know is harmful and we know kills 480,000 people a year. And frankly, it just blows my mind, right? Like, why aren't they having workshops? CDER, CBER, CDRH, right? The Drugs, Biologics, and Devices Center, they have workshops, guidances, rulemaking. And granted, I 100% agree with everyone that they need the staff and the resources to do that. But we have to start that conversation to make sure that they get those staff and resources so that that transformation of that center can happen, so it can be just as good, if not better, and it should be better than the other product centers, precisely because of the harms of the product market that it's regulating.
Yeah, I was going to just slam home the point that Georges and Boris set up for me, which is that there is a legal mechanism that the FDA could use right now that they are just not using to incorporate a lot of comments and public opinions. It's called the notice and comment rulemaking procedures. And I know that Dr. Bouchon said that he likes to legislate every sort of regulatory decision. But in reality, the FDA makes its own laws at about a 10-to-1 ratio compared to the black and white letters that are written by the legislative branch. And they're allowed to do that because of this notice and comment rulemaking that's allowed in the Administrative Procedures Act that gives the agency's rules the force of law if they go through this notice and comment procedure. And that incorporates, they have to field comments from everybody, and they have to respond to them in the Federal Register. And that's just, a nice way to formally recognize all of the comments from different sides. And functionally, there's growing arguments that they need to and should have been doing this for their ends products, quasi-product standards. And yeah, I just think that, to defend CTP, they did have a workshop recently about PMTA applications and the contents of them. They have TIPSAC, which is
They haven't used
Right,
the Tobacco Product Scientific Advisory Committee. They haven't really used that very much.
They don't use it, but it's there. But they have not used notice and comment rulemaking, which I feel is absolutely essential for making product standards.
How do you think that they can improve the transparency of the review process?
Yeah, I think the big issue was it's kind of being played out in the Fifth Circuit right now. We're awaiting this big en banc decision from the Fifth Circuit in this case called Wages and White Lions. And basically, the narrative that's played out in that case is that on one day, the FDA issued denial orders to 55,000 flavored products. And they did this without any sort of ex-ante proactive product standards, which meant in theory they should have been reviewing those 55,000 applications and these 6.7 million applications one by one by one. But the fact that they rejected 55,000 all within the flavored category all in one day brought that into question. And it turned out that they circulated this memo internally called the Fatal Flaw Memo, which kind of retracted what the agency had previously said in a guidance document, where they told industry, you're not going to need long-term studies, you're not going to need like prospective RCTs, you're not going to need longitudinal cohort studies. But then in this internal memo, it said, yeah, we are going to require those. So any PMTA that does not have a longitudinal cohort study needs to be rejected today. And once that memo came to light, the courts have started to increase their scrutiny of CTP's decision-making processes. And we're still, like, the oral arguments for this case happened in May. So we're still waiting this decision from the Fifth Circuit. But a preliminary one was very, very antagonistic to the FDA. So I think a lot of legal scholars are anticipating this en banc decision to be, again, critical of the FDA, at which point we might need to see this escalated to the Supreme Court.
So it sounds like you think that improving transparency of the product standards by which products are then graded, right, either authorized or denied market entry, is an appropriate process to, or an appropriate way to improve process, make sure that more harmful products are kept off the market, and that products are potentially appropriate for the protection of the public health, which we're all public health folks. It's interesting because that's actually an epidemiological regulatory standard for which we currently don't have guidance about how it's defined.
But there are fatal products, right? I mean, we have to agree there are things that should never be on the market because they have lead in them. They have arsenic.
Absolutely,
right?
and which is precisely why we need product standards.
Right. And the fact that, remembering that on the drug side, it's about safe and effective. On the tobacco side, there really isn't anything such as safe, right? Or effective, because they're not a therapeutic product.
So I had along those lines, actually, there's been a lot of debate about harm reduction in the tobacco space. Some people think it's a real thing. Some people think it's fake. And there's a range of opinions. What do each, recognizing, of course, the current regulatory framework is far from perfect, that we need better marketing, advertising, and distribution guidance and appropriate protections. Do you think that there exists a continuum of risk for the use of tobacco products?
Well, let me begin with this from sort of the perspective of what we have now. So you light up something, right? That's a plant, right? You suck it in, it goes into your lungs, right? That's the most common use of tobacco as a burnt, as a combustible product. Now, depending on who you believe, and, the 6,000 to 7,000 chemicals, right, in that burnt product, of which 60 to 70 are known carcinogens. So as a preventive medicine guy, my sense is, okay, let's not do that. 6,000 chemicals, 60 carcinogens, where, right, when it comes to fatal things, you're not going to discover this right now. It has a long history. It interplays into the history of the founding of our nation, tobacco does. But people, it's the 21st century. We got the facts there. And so when we talk about harm reduction, although traditionally public health had been, no. Our goal is elimination, period, stop. My sense is if I'm up against 6,000 chemicals and 60 carcinogens, I'm looking for anything that will start saving lives, not a generation from now. I'm looking for anything that will start saving lives starting tomorrow, provided it doesn't introduce more harm than I have right now. Harm reduction, not harm equality, not harm expansion. I'm looking at harm reduction. That saves lives. So my sense is, as a public health practitioner, as now a dean of a school of public health, I think it's worthy of us, for the saving of lives, for the caring of individuals, for the concept of health as a priority in our nation, we need to be looking at that.
And we do harm reduction all the time, right? We do it when we treat diabetes. We treat it when we do hypertension. So the concept of harm reduction isn't a foreign concept. So let me agree with Boris. I think that the issue here is how can you help prolong life, reduce disability, and clearly the idealized system is never for kids, right? We should not allow kids to happen. Now, we're doing this in an environment in which we have a legal product and we have an industry which is working to sell that product. Tragically, they do that in a way that's very aggressive, and our resources on the public health side are dwarfed by the resources of the industry, right? So the industry is actively promoting the product. They would argue that they don't promote to kids. I don't agree with that. I disagree with that. Most people that start tobacco actually start underage in their youth, and they've been marketed to. They've been focused. They've been profiled in order to help them do that. The industry will argue they don't do that, but bubble gum and other flavors belies that. Although I have to admit, as people do like bubble gum, but they are clearly marketing when you look at targeting folks. And even if you argue that they try not to go for youth, they certainly do young adults.
So along those lines, do you think that more, hypothetically speaking, more aggressive advertising and marketing regulation coupled with a better product regulation scheme could help advance tobacco product regulation to improve the public health?
I think the best way to improve health is through a complex, interrelated series of education, regulation, and prohibition to populations that should never do it. In this town, when I was the health commissioner here in Washington, D.C., we did a whole host of things, including educating youth, putting vending machines behind, in bars and restaurants only. We put them in other places behind the cash register so that you had to card an individual to sell the product. And obviously, all of the efforts that we've had around marketing restrictions, I think, have made a big difference. And if you look internationally, the very vivid, aggressive imaging and marketing efforts, anti-marketing efforts they've done on tobacco have made a big difference. And the truth is, we need to do the same thing with vaping.
How do you think we can get for both George's and Brian, it sounded like you had something on the tip of your tongue, how do you think we can get the FDA there? Because it seems like they aren't. Either one of you.
It's a really tough question because it's hard to know how the FDA or CTP specifically would react to any judicial ruling or new legislation. But the one thing that I definitely wanted to bring back in was what Dr. Bouchon said up front, which is that outright bans don't work, and they won't for this nuanced approach that George has just mentioned, is that outright denying a PMTA is too blunt of a policy tool to achieve what we're going for. Because for every, vape that's not out there, sure, a youth isn't going to have access to it, but neither will a current smoker. And so outright banning a product is not the way to strike that nuanced public health approach.
So if I'm parsing this correctly between the two of you, it sounds like it's more of preventing access as opposed to preventing the product.
Yeah.
Well, it depends what your goal is. If your goal is harm reduction, which I would argue I would agree with, then you got to have a more nuanced approach. Because there are people who will do better, adults, not children,
Right.
Adults who may do better if the ultimate goal is cessation. Now there are other tools we can use so that you don't get dual use, right? The concern, of course, is the person who vapes when they're in a place where it's okay to vape and use combustible tobacco in other situations. And the idea is what you really want to do is like with nicotine gum, you want to be able to get them off this terribly addictive substance completely. I mean, that's the ultimate goal.
I just wanted to chime in on the harm reduction conversation because there's kind of it's like evolved over the course of the last decade in medical education, I would say. And it's because of the opioid epidemic. And I kind of saw the teaching change in front of my eyes in med school because of the opioid epidemic. Like all of a sudden we were okay with things like safe injection sites, needle exchange programs, prescribing opioids to treat an opioid addiction. And these are things that, old school medicine, it would just be like, no, don't do that. Don't use opioids. Don't use tobacco products. Whereas now we're accepting that we have to meet patients where they are and meet them halfway. So I think that tobacco is so obvious because the TCA allowed combustible products to exist on the market. So they set up what the harm is that we're trying to reduce in the initial piece of legislation. But I think the problem is, and getting back to your question about how do we get the FDA to commemorate harm reduction in practice, is the definition of appropriate for the protection of public health must be done in light of the fact that combustible products are still on the market. It's not in the legislation right now. So when you read CTP's decisions for denying things, they almost ignore that fact and they treat every application as if it's coming into a world with no nicotine.
With no tobacco product use, whereas currently there are 30 million people using combustible tobacco products, and CTP doesn't, for some reason, consider that. We're going to open up to questions from the audience and also online. I also have some questions here that I haven't gotten to, so selfishly, I'm going to get one of mine in, which is, right now we're in a really weird marketplace, right? So there are a couple manufacturers that have authorized products that are on the market, and then there are lots of illegal products, many of them imported from foreign countries, that if the FDA shuts down that product manufacturer, they just change the location of the LLC's post office box and have it come in another shipping container. How do you think we address, or what is the best way, if there is a way, to efficiently and effectively address the flood of illegal ends products from foreign markets?
To me, it sounds like a ATF, alcohol, tobacco, firearms, illegal importation kind of problem, and not a public health FDA problem. FDA is kind of a nerdy scientific product regulator and not a police officer. So the fact that they've devoted so much time and energy, bird dogging down the illicit market, I think has probably delayed some of their product regulation.
And then another question that we have here is about the TPSAC. So the FDA centers have a variety of advisory committees, right? Like the Center for Drug Evaluation Research, Center for Biologics. They have the ONC Products Advisory Committee. The Devices Center has a bunch. The Tobacco Products Scientific Advisory Committee has really met more than once a year, maybe sometimes twice. What are questions that you think the FDA should be asking that advisory body, and what do you see as the missed opportunities?
Well, I think, first of all, again, I don't have the data. You seem to have the data of how often they meet. Partly is you can't necessarily treat an advisory committee of any kind if you don't have them actually gather and have questions posed to them. So first of all, meet more often, set up agendas. I think to large extent, the appearance of the outside world is that, although, and I spent 6 years at FDA myself, is that, in those 6 years, I actually learned how to appreciate, right, the Food and Drug Administration as a regulatory public health body. And this is after 16 years at CDC, where initially I had a culture shift, right? It was from one to another, but I realized what an important role they do play. I think that needs to be reinvigorated on the tobacco front. And part of it is you turn towards advisory committees and ask them even simple questions. What do you think we should be doing right now? How do we handle all these issues, right? I think there needs to be a boldness and then, a reaffirmation of the mission, right, of the Center for Tobacco Products. Be bold again.
Welcome questions from the audience. I have one here electronically. What role do you think that the health insurance industry should play in tobacco regulation, if any?
Well, they spend a lot of money on tobacco-related diseases. So I would argue investing in both education, programs, particularly big investments in cessation therapy, making sure that patient access to cessation therapy is as inexpensive and as easy as possible to get. At the end of the day, they want to reduce their costs. That's the best way to do it. So I actually can see them as a critical business partner in terms of doing that.
Boris or Brian?
Yeah, no, I agree. I think, again, when we look at the stakeholders and all this, I don't think we've really tapped fully into anybody at this stage, right? Again, it's a reminder to some extent that somehow we've become quiescent on the tobacco approach. And granted, we've been taken in multiple directions with multiple public health crises, right? Certainly the pandemic, right, took us into a different life. Opioids took us into a different life of crisis there. But what's been a constant for 60 plus years, right? And even before that, right? Don't forget, 64 was the game changer because the first acknowledgement, right? In the Surgeon General's report saying, hey, this actually may be bad for you. But don't forget that first report only said one thing, right? In terms of a risk. It was all about lung cancer in men. That was the result of this 300-page report, lung cancer in men. And what we've had now 32, 33, 34 Surgeons General reports since then, each of them jumping off the previous one saying, hey, we have actually more information now. And I think the stakeholders need to sort of reaffirm it. You get sick and tired, I think, after a while saying, well, we've been at this for a while and we've done as good as we can. Let's move on to something else. No, we're actually this close, right? If we had given up on smallpox, vaccination programs internationally, would we have eliminated smallpox off the face of this planet? With an international and a concerted effort, if we said, hey, it's good enough. We don't have it here in the United States. So I think that's one approach on this. The other approach you also have to acknowledge is, guess what? We don't do well as a nation necessarily on public health parameters, except when it comes to the smoking thing, right? Spend a little time in Italy like I did a month ago where a lot of people are smoking, despite the graphic warning labels, right? So we're actually doing pretty good. So this should be, again, a national tap on the back of how close we are. So the stakeholders, be it insurance, the stakeholders, be it, governmental public health, the stakeholders, FDA, right? It's going to take a village, and let's start re-establishing that village again.
Brian, what do you think about the insurance industry? A role here or none?
Yeah, I would love to see an insurance company start mailing ENDS products to its active combustible users. I know you think that's radical, but UK is doing it right now. And
it's a public insurance company too.
Right. It would require, FDA authorizing enough products out there for consumer uptake. But I think that would be a very great approach. If insurance companies are willing to pay for people's gym memberships, why not?
It's actually interesting that the National Health Service is doing that as a swap to stop campaign. I'm not sure that domestic insurance companies will probably go that far, but do appreciate the thought.
But one thing they could do also is they could show up at the public health hearings locally. Mm-hmm. They always show up to get their rate increases. But it would be nice if they would send their lawyers to support the public health department's regulatory activity. Mm-hmm. Obviously, I believe in using tax increases also as a deterrent. But I would love to have had them show up at all of my public health hearings to help me push responsible legislation through.
And let's remember, again, if we look at both the the health insurance industry, whether it's U.S. government, Medicare and Medicaid supported, whether it's other mechanisms of healthcare costs, let's remind ourselves of what kind of dollars we're talking about, right? The latest numbers are what, 4.2, 4.3
$1 trillion.
trillion, with a T, $1 trillion spent on quote unquote health care. And we'll be the first to admit it's really not health care, right? The definition of health by the World Health Organization is complete, it's physical, mental, and social well-being, and not merely the absence of disease and infirmity. It's sick care. $4.23 trillion for sick care, over nearly $13,000 per person in the United States. So of that, what percentage is spent on prevention?
About 3%.
About 3% of that $12,000. So when it goes back to the insurers and everybody else, this is prevention. We're talking prevention here when we're talking about, ENDS products, when we're talking about tobacco, the fight against tobacco, and yet only 3% of the $13,000 per person is spent on any aspect. So we're throwing all this money away to treating all these problems, but in fact, again, not getting ahead of the curve on there. I think we have a responsibility from insurers' aspect and from all the stakeholders to look at that.
I agree. Question from the audience?
Yes, thank you. Thank you guys for this fascinating conversation. I actually have two questions if there isn't anyone else that has one. My first is around the state of affairs around things like flavor bans. We talked about, you all talked about kind of the importance of complete smoking cessation and trying to avoid dual use at all costs when trying to get individuals to kick the habit. But it seems with flavor bans, that's a little bit counterintuitive because we're making products that are not combustible tobacco products taste like tobacco. And so wanted to get your thoughts on where you think there is value in disassociating from the flavor profiles from kind of traditional combustible cigarettes with flavored products. And then the other question that I had as well is around the user fees component. So we've talked about user fees quite a bit today and wanted to get your thoughts on, do we think that there is value in generating user fees into regulatory pathways that have a lot of operational inefficiency? You just mentioned the UK swap to stop program. Their regulatory apparatus is very much built on get the products out there, ensure that they are safe, they're not going to catch fire, they're not going to explode, and then do post-market surveillance to generate the longitudinal data sets on improving public health. And it seems like the market is not waiting for FDA to generate 50 years of longitudinal studies and research to get these moving. And so those are the two questions. So one around the flavor ban and making products that do not contain tobacco taste like tobacco products. And the other is, should we be dumping more or collecting more money into pathways that are already distorting the market in a way?
Someone want to start with the flavor ban question?
Yeah, I think that the flavors make the utilization of particularly combustible tobacco even worse, but also the fact that at least right now the flavors are helping precipitate children's use of vaping products. And so I believe that we should ban those flavors. The other issue about let's not confuse user fees with administrative inefficiencies. We should adequately fund what we have in any system. Any business ought to be adequately funded. And then we ought to make sure that the administration is done efficiently. There needs to be accountability and oversight and all that. We have very inefficient systems, and we need to make them more efficient. And there are ways to do that.
I would add that user fees can actually be a chassis for making a system more efficient. Because with the additional funds, and I'll defer to you in a second, Brian, with the additional funds comes performance metrics for regulatory, metrics for regulatory performance. I was a reviewer in CEDAR, and I knew that if I didn't get the new drug application or NDA done by the statutory deadline, I'd be sacrificed in front of Congress. And that's only half a joke. because that actually was a threat that was given to reviewers. So having that sort of performance of timeline for the PMTA or MRTP process could go a long way towards improving CTP's performance for getting a product application in, reviewing it, and making a decision about a marketing authorization or denial. When you have that also general infrastructure in there, and a lot of this is not really visible to the public, but there comes a lot of meetings, right? So like when I was a drug reviewer, you had statutory scheduled meetings with the company. You also had ad hoc meetings when you were looking at this mountain of data on a server. You had a specific person, not the reviewer, but a specific person who interacted with industry, a regulatory project manager, who you could ask to send various questions to the industry sponsor, the sponsors they were called, to get a specific clinical question answered, a trial design question, have them do an additional analysis for you, have them, consider doing another study, whatever it is. You had regular interactions with the industry. Right now, unlike all the other centers, the Center for Tobacco Products doesn't do that, which, again, to me, as a former product reviewer in CDER, is a total mystery, right? This is the one product we know that causes morbidity and it causes mortality with long-term use. And so the product regulator is not having regular meetings and debates over scientific and clinical and epidemiologic questions with the product manufacturers. To me, just completely blows my mind. So having user fees creates metrics and processes and accountability, and also provides a lever for Congress to have oversight, because this is also an oversight issue. Why is the agency getting away with spending lots of money and, as I said, being the passive-aggressive regulator, right? Like, it needs to be making decisions in a timely fashion. The pediatricians had to sue them to get them to make decisions.
Yeah, the first Prescription Drug User Fee Act was viewed as like a quid pro quo. Like, you'll get money from the pharmaceutical industry, but in exchange, and this is in the statute, FDA must come up with a review timeline. If they don't meet it, bad things can happen reputationally.
And loss of funds.
Loss of funds.
Loss of staff, then, as a consequence.
I got this phrase from Brian Miller. We consider user fee acts like golden handcuffs. They're made of gold, but they're definitely more handcuffs for the agency.
Right, and it's not, to be clear, it's not a handcuff to the industry, it's a handcuff to the agency for accountability to the public health.
Mm-hmm. Like, you must issue notice and comment rulemaking for product standards by certain date. That could be in a user fee act.
Did we answer all, or was there a third question in there?
No, there were two.
Okay. And then there's a question from online, which I think will be our final question. It's, quitting tobacco is one of the hardest things that addicted people can do to improve their health. Where do you see a role in bringing more effective therapies to the prescription market, as well as bringing existing therapies like Chantix to over-the-counter or OTC status? So I would say, how do we get more prescription products available to help people quit smoking, and how do we get those existing products into the OTC space? Is it possible?
Yeah, one of the wonderful things about our nation is that we have an extraordinary scientific enterprise here, which we have spent a lot of money investing in. This is one area we need to invest more money into cessation therapies, both through the NIH, both on the actual pharmaceutical part of this, as well as research on the behavioral part of it. We just need to spend more money doing the research.
And I mean, the question about the OTC switch is actually an interesting one. A lot of other countries have a different category in addition to OTC called BTC, or behind the counter. Right? Like in Australia, I think France too. And so if we had a behind the counter product category where products, it's not that the pharmacist has a license to prescribe, but the pharmacist serves as learned intermediaries. The patient comes into the drugstore, and then they go and talk to the pharmacist about their health concern, and the product can be dispensed them without a prescription, but only with an interaction with the pharmacist. That's a potential channel. I can't say about a specific product, but it's a channel to expand and democratize access to smoking cessation therapies without changing licensure, without having to address insurance and all those other complex systems, and using pharmacists, of which I think 95 or 96% of Americans have a pharmacist within a mile of their house, or several miles of their house. So that would be an answer to expanding potentially OTC access. So almost OTC.
In terms of tobacco cessation as like a medical indication, I think that the history of how ENDS products were viewed between CTP versus cedar is really illustrative, because at first it seemed like there were a lot of companies that wanted to market them as a medical product, as nicotine replacement therapy. But the FDA, in an agency-wide decision early on, said, no, these are more tobacco products, so submit a PMTA. And I think industry was happy at that time because the data that's required to go through CEDAR to get a medical product approved was thought to be very burdensome at the time. Turns out PMTAs might be more burdensome than that. But we are seeing, as the data evolves, and that's the other thing, is data has been evolving. When I was a resident, I did all my primary care work at the VA, and getting vets to stop smoking is very, very tough. And every option that was available, I would try to discuss with them. And this was right around the time that the evidence coming out for ENDS products for cessation was starting to evolve. And the Cochrane Review has literally changed every year about how effective it is as a cessation tool relative to CEDAR-approved NRT. So I think we're starting to see the pendulum swing back, where these newer ENDS product-only companies are going through CEDAR as a medically approved product as opposed to a tobacco product.
So I have one final question, and I'm hoping for short answers given that we're over time, which is, what is the one thing that you think Congress should do to improve the FDA regulation of tobacco products? I'll start with you, Georges.
All right, I think they need to adequately resource the FDA.
Boris?
The congressman said it, every agency wants more money. 480,000 people every year are dying, and we're not putting in the effort to this. So it's funding, staffing, and it's that oftentimes leads towards a reaffirmation of the mission.
Yeah, I think a user fee act with those things that we've talked about to kind of tie agency action, specifically a notice and comment rulemaking for product standards for ENDS products. I think that would move things along really quickly.
Well, there we have it. We may end up with a user fee act. Well, thank you all for joining us. This has been a great discussion. I appreciate everyone taking the time out from their afternoon, and looking forward to continuing the dialogue.
Thanks, Brian.
Thanks.